again presented by my dear colleague, Dr. Mohammed Makki, who is a consultant in allergy and immunology in Damat Al Imarat Hospital here in UAE. Hello, Dr. Mohammed. Yep. Shall we start?
Yes. Give me 1 second. Let me just share my screen. Yes.
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 Good. Very good. Hello, everyone. Good evening. Thank you all for joining us. Thank you, Dr. Heba, for inviting me to give this talk. And thank you, Dr. Vovio, for your very interesting case. I'm also going to speak about an inborn error of immunity, a case that I've seen in the hospital where I work. I'm working in Danat Al Imarat Hospital here in Abu Dhabi. I've been working for the last 2 years, and this is one of the more interesting cases I've seen. This patient presented to me in July of 2024. So he's in Danat Al Imarat, we see adults and pediatric patients. I'm lucky enough that I am trained in both, and I am licensed to see both. And thankfully, we see all ages. And this is one of the cases that were interestingly referred to me from another center, from a pulmonologist actually. That was in July 2024. A 9-year-old boy came in for recurrent infections. He was seen by multiple doctors in the past, as you will see in the next few slides. And finally, thankfully, a physician decided to send them to see an immunologist to do further workup. So let's get started. So let's go with the infection history. And basically this, when I went and reviewed all his charts, thankfully in Abu Dhabi, we have a connection between different hospital charts, and a lot of his treatments was in Abu Dhabi. And also by asking the parents, the mom is actually a physician herself. So she was able to give me a lot of details, and I was lucky in that regards to get very good infectious history. So starting age 4 months, he was his first infection. That's when he developed pertussis, according to mom. They were living at Sudan at that time, and he was treated by the age of 6 months for that. According to the mom, he was admitted. He was not intubated, but it was a severe infection. Later, from the age 4 months to 2 years, he had no major infections until the age of 2, where he developed abdominal bloating with certain foods, and he wasn't gaining weight. At that point, he was diagnosed with possible megacolon on CT scan that, according to the mom, resolved actually just with some dietary change and some restriction of food. Although from the history, it seems that there was a continuous inflammatory process, but no infections were identified at that time. He was, of course, on multiple antibiotics as part of the prophylactic treatment they were giving him because of the presentation. Then from the age of 3 onwards till the age of 9, he continued to have recurrent chest infections, specifically pneumonias and bronchitis. According to mom, about 6 to 7 per year. He required azithromycin, he required augmentin, multiple antibiotics, IV and oral, and multiple admissions. The latest infection was 2 weeks prior to his presenting to me, and he was admitted in one of the other health centers in the UAE, where he was given IV antibiotics. According to the mom, at that point, there were no major sinus or infections as far as she can remember. He did not get COVID. He was never at any point diagnosed with sepsis, no positive blood cultures, no history of meningitis, no septic arthritis, no osteomyelitis, no fungal infections, and no thrush, and no history of extensive or bloody diarrhea. And she also denied any skin infections. On review of systems, he had a pretty low weight for his age, and his appetite was low. Unfortunately, I did not have a growth chart for him, but according to the mom, his weight has been stable for the last couple of years. At least he hasn't been gaining weight. He did not ever have fevers with no other symptoms, isolated fevers, no isolated night sweats or chills. He was never exposed to TB. There is no history of systemic GI, respiratory, or cardiovascular symptoms, no joint pain or swelling. There was no any oral ulcers, no flushing, and there was no past history of any urticaria or eczema. His last travel was to Sudan in 2018. They moved to the UAE around the age of 3 years, when he was 3 years old. In terms of birth history, he was a full-term baby boy delivered by C-section due to fetal distress. However, he did not need to stay in the NICU. He had no other complications and no maternal complications during pregnancy. He never had any surgeries. His admissions is as we discussed before. In terms of vaccines, he received all the vaccines required by the UAE. He did receive BCG. He did not receive flu vaccine. In terms of family history, both his parents are from Sudan. They're not cousins. They're not related to each other. He has an older brother and older sister, both of which are very healthy with no recurrent infections. There's no family history of immune deficiency, autoimmunity, or cystic fibrosis. Mom had only one first trimester miscarriage because of chromosomal abnormality. She wasn't sure of the actual results, and no history of early infant deaths. In terms of examination, he was a very thin boy, no dysmorphic features. Otherwise, the examination was really unremarkable. His cardiovascular, respiratory, and GI systems were all within normal limits. He had some hypopigmented skin lesions in the arm, which were attributed to be like insect bites. So when he came to me, of course, he had a bunch of lab tests done in the past. The ones that were more significant were done actually in April of 2024. And they found at that point that he had no IgA, zero IgA. But his IgG and IgM were normal technically for age. His IgE was also normal. He had HIV testing that was negative, quantiferon testing that was negative. His chest CT and the chest X-ray, however, were abnormal. Chest CT was done. Unfortunately, I don't have the images here, but they basically showed a bilateral evolving bronchiectasis. He also had a positive ANA. At that point, because of bronchiectasis, the no IgA, he was referred to me, and the recurrent infections, he was referred to me by the pulmonologist who was taking care of him at the time. So just to summarize the case before we move to the next part, this is a 9-year-old boy with history of recurrent infections, mainly chest infections, possible megacolon in infancy, positive ANA, bronchiectasis, and no IgA. So I guess my next question for you is, what are your differential diagnoses? I don't know, Dr. Heba, do you want this to be a little bit interactive, or should we just proceed with the differential diagnosis that I thought of?
People can put their comments in.
I cannot see the
We have
way
for
when
comments open, but I think it'd be very nice if you can get your comments. So somebody's asking, any history of CMV colitis?
No. By the way, Dr. Heba, I'm sorry, I can't see the comments or anyone's faces, so I'll have you help me read.
I'll ask them. And any eczema, skin lesions? No, just the hypopigmentation from the insect bites, no skin lesions.
Yes.
Do we have colitis from the megacolon?
Say that again,
was
sorry.
a long time ago, wasn't it, in Sudan?
Yeah.
Do you hear me, Dr. Mohammed?
Yes, I hear you. Yes. What was your question again? Sorry.
The other question was a colonoscopy done?
No, it was not. No colonoscopy or endoscopy was done.
And they asked about CMV?
No CMV infection, as far as the parents know. And from what I've seen in the review of chart, no one even checked at that point.
Okay, I think we can proceed.
Okay, so I guess when we have a case like this with symptoms mainly focused on the chest, especially now at older age, some of the most important differentials that we have to think of are chest-related issues, right? So on top of our differential at that point were things like cystic fibrosis or primary serial dyskinesia. But of course, as immunologists, it's important for us to think also of immune deficiencies, especially that I know that there is a history of this megacolon, there is a very low IgA. We do know that isolated IgA deficiency by itself is unlikely to cause such extreme symptoms. The majority of patients with IgA deficiency are usually asymptomatic, and if they do have symptoms, they tend to have specific GI and respiratory symptoms, but not to this extent, and definitely not to an extent where he's admitted 6-7 times a year. So IgA deficiency was not a big thing for us, but it's definitely something to think of. CVID is more of an umbrella term. Of course, there are so many different genetics under CVID that can present this way. Hyper IgM syndrome should be considered. Severe combined immune deficiency, yes, especially like the leaky types or the hypomorphic mutations can present with something like this. And lower on our differential are things like ALPS and ALPS-like disorder, where patients will have more autoimmunity rather than infections, but this is something also to keep in mind. So these are some of the differentials that we thought of, especially that he had a positive ANA. We
I
put
think we've
in.
lost you, Dr. Mohammed.
Oh, you cannot hear me? Hello?
Hello. We've lost you
Hi.
for a bit. Sorry, we've
Oh, okay.
lost you for a minute or two.
Oh, really? Did you guys hear what I was saying about the
Yeah,
differentials or
you
not?
were talking about severe combined immune deficiency.
Yeah.
Yeah.
So, like hypomorphic mutations, SCID, things like Omen syndrome or leaky SCID can present with a milder form that can be discovered later on in life. And that's something we also wanted to keep in mind. And other disorders like ALPS, ALPS-like disorders, and lupus specifically with his positive ANA. So these are some of the differentials that we thought of. And we started doing our workup based on these differentials. So first of all, a basic CBC showed that he is leukopenic, specifically neutropenic. His total neutrophilic count was 180. His ALC was 1,360, which was also low. He had normal liver function metabolic panel. Bronchoscopy was done by the pulmonology, which showed normal anatomy. The BAL fluid cytology had no apparent lipid-laden macrophages or abnormalities or malignant cells. The CF sweat testing at that point was negative. In terms of immunological workup, we started off by repeating the immunoglobulins, and you can see here, I don't know if you guys can see my cursor, but basically his IgA was significantly low. His IgG was still within the normal range for his age, and his IgM was high. We looked at vaccine titers. You can see that he had no titers to Haemophilus influenza, and he had no titers to measles, which indicates a possibility or damage in the functions of B cells and probably also T cells. When we looked only at B cell function by looking at pneumococcal titers, we saw that there were no titers whatsoever for the pneumococcal vaccine for any of the 23 subtypes. And note B that this patient received all his vaccinations. However, interestingly, the tetanus antitoxin antibodies were there. So he did have some amount of immunoglobulins to tetanus. So the vaccine did work partially for this patient. When we broke down the IgG and looked at the subclasses, he significantly had low in IgG2, however, normal or elevated the rest of the IgG subclasses. So at this point, we have no IgA, low IgG2, and low vaccine titers for the majority of them. We also checked his complements. CH50 was normal, C3 was normal, however, his C4 was low. And finally, most importantly, we did the lymphocyte subsets. I kept this to the end because this will kind of indicate what's happening over here. And you can see here that the main thing that the patient had no B cells whatsoever. 0 B cells. He had normal T cells and slightly low NK cells. So this patient had B cell lymphopenia, completely no B cells, no CD19 cells, low NK cells, and normal T cells. At that point, it was a very confusing picture, to be honest. I spoke to Dr. Hiba, I spoke to some of the other colleagues. How can a patient have no B cells but have some amount of immunoglobulins and normal IgG? We did suspect at that point that maybe XLA, maybe in the picture, there are forms of leaky XLA, but they're very rare. I spoke with the parents at that point, and the discussion was how to proceed from there. So this is a summary of all the results. So far, this patient had neutropenia, lymphopenia, 0 B cells, low NK cells. He had low IgA, low IgG2, but normal total IgG, and high or normal IgM. He had low measles, H flu, and pneumococcal titers. And he was positive ANA with a low C4 level. So it was a really very confusing picture at that point. Like it wasn't something that's fitting the book, what we read in the books in terms of immune deficiencies, nothing clear cut. So In the meanwhile, by the time all the results came back, the patient was admitted another time in the hospital for pneumonia, and he was discharged on oral Augmentin. He even developed an acute otitis media despite being on oral Augmentin, and required ceftriaxone injections to clear that up. I sat down with the parents, and we were discussing the different options. And from here, we either had to do either functional testing or genetics. Functional testing, as many of you who are working in the UAE and maybe in the Gulf region, not all the Gulf, probably certain places, they're not very accessible to all. And even if we do have the ability to do functional testing, they're very expensive and they're very time specific. So when you draw the blood, you really have to get it there to wherever the lab they're going to do it in a specific time. So it was very tricky to go for that. So we wanted to start with genetic testing. We had multiple genetic options. Unfortunately, the patient's insurance did not cover genetic testing. This is a problem that I'm sure many of my colleagues here have encountered. So we had to sit down and try to figure out the one that is going to be most useful and also not financially ruin the family, because they can be very, very expensive in this part of the world. We eventually opted to do a new generation sequencing panel for 474 genes of primary immunodeficiencies. We did it in a local lab that we have here. And we got the result actually quite fast, like within 2 weeks, we got the results. And then meanwhile, while we're waiting for the result, we did start the patient on azithromycin prophylactic antibiotics. Of course, no live vaccines at that point, and contact precautions with precaution to come to the hospital whenever he has a fever. So we got our genetics back. And interestingly, we did find a pathogenic variant in homozygous state for the BTK gene. And many of you know the BTK gene, the Bruton tyrosine kinase gene, is important for, it's the pathogenic gene. It's the gene that is affected in patients with X-linked A-gamma globulinemia. This mutation actually was located in the splicing region in intron 15 of the BTK gene. So it's an intronic mutation, not a typical exonic mutation. And when they did an mRNA analysis and C2 analysis to see if this mutation is pathogenic or not, it actually, the deletion of this intron lead to a splicing defect resulting in loss of both exons 14 and 15, which will in turn lead to an in-frame deletion of amino acid 451 to 544. And these amino acids are the ones that are found in the protein kinase domain of BTK, which is classified basically as a pathogenic variant. So it's very clearly this mutation is associated with reduction in protein kinase domain and BTK function, which might explain why this patient have no B cells and very low immunoglobulin IgA, specifically like 0 IgA. It still doesn't explain, of course, that we still have some IgG remnant. So at that point, I did some literature review, and I was trying to find if this mutation is reported to be associated with hypomorphic mutations of BTK or what we call leaky XLA. So these are patients who do not have B cells, but still retain some degree of immunoglobulins. But these immunoglobulins are not very functional. And this is probably what our patient has. From the case reports I found, it seems that there were variable presentation. None of these patients that I found, at least in my search, had a similar appearance of very, very high IgG, but they did have variable presentation of their symptoms. For some, it was very bad, and some of them passed away at a very young age, and others were still alive and on immunoglobulin replacement. So at that point, we sat down with the parents and we discussed our different options. We started the treatment of the patient with IVIG, actually, and while we were thinking and applying for insurance approval to get him HyQvia. HyQvia, as many of you know, is a form of subcutaneous immunoglobulin, but it is infused subcutaneous immunoglobulin. It's a combination of hyaluronidase that initially increases the space within the subcutaneous tissue, and then we give the high dose of the subcutaneous immunoglobulin which can be maintained for a long period of time, 3 to 4 weeks, instead of the usual subcutaneous immunoglobulin, which is done like on daily or weekly, very close basis. Of note, we did repeat his ANA and C4 levels, and we did some, of course, pre-infusion tests. The pre-infusion tests were all negative. He actually did not have hepatitis B S antigen or S antibody despite being vaccinated. So that's another vaccine response he lacked. His ANA became negative on repeat. So that might have been a false positive. As many of you know, ANA sometimes can be falsely negative in patients. And there is a good percentage of patients in the general population with no lupus or autoimmune manifestation that can have a positive ANA. His C4, however, remained consistently low. On three different occasions were repeated, and they're always low despite a normal CH50. So now the patient is actually doing very, very well. I'm happy to report this is a happy story so far, alhamdulillah. He's now on HiQVia since the 23rd of January. He's taking it every 4 weeks. I actually saw him today. He's doing very well, gaining weight, no further infections. He has the odd cough on and off, and he's following up with the pulmonologist in tangent with me. We're doing regular pulmonary function tests, and everything has been improving and well. His chest X-ray cleared. We're planning on repeating CT scan soon, and otherwise he's doing well and thriving, and all is good. In terms of the elevated IgG, at some point we were thinking that maybe there is some sort of underlying malignancy or abnormality in the immunoglobulins that leads to this excessive increase in the IgG or the normal amount of IgG despite him supposed to have zero IgG. So we did do serum protein electrophoresis, but that came back with no M spikes and no indication of malignancy really. Thank you all for listening. And now I guess we can go ahead with the questions. Let me just stop sharing my screen.
Thank you very much, Dr. Mohammed. A very, very interesting case and quite atypical and bewildering. So that I think the lesson here is go for the clinical picture. Although he just had a low IgA, he was behaving like an antibody deficiency, like a combined, like a complement. He was behaving like somebody with significant disease, and that you go and look and you dig really hard to try and establish what's going on.
And really something as simple as a lymphocyte subset in this case was able to like move us towards doing genetic testing. And this is, I feel, a test that can be done not only by immunologists, like this is a screening test that can be done also and by other specialists. So if this was done earlier, really this patient would have been spared a lot of suffering and a lot of admissions.
Exactly. And the bronchiectasis as well.
Yes.
Probably.
Yes.
And I think I remember when we discussed him, I mentioned to you that I had actually a leaky skin who presented with recurrent chest infections, bronchiectasis, and had very low B cells, and the T cells were normal high. And it was on TREX and naive T cells and genetics that we actually picked up that it was a leaky combined, not leaky.
Not leaky XLA.
And the picture wasn't very different from your patient, but it was younger. It was at a younger patient.
Yeah. Those leaky patients really, they present very, very differently than what we're used to on books, at least. They can come with a very combined picture, very non-specific. And that's why this goes back to what Dr. Fovio was saying, like genetics is now very, very much needed to pinpoint a diagnosis and to help the family understand what's going on and also plan for the future. What's the risk for other children to get infections and so forth. So, yeah.
Exactly. Early diagnosis and to start immunoglobulins early, or if, it makes a big difference. So Dr. Mohammed Yusuf Karim is asking you, did you consider vaccine response? Did you challenge him? Did you vaccinate him? And see
I actually did not. I did not consider that. I think with the genetics, after I got the genetics, at the very beginning, yes, the plan was to revaccinate him and see how he's doing. But at the point where I saw there is 0 B cells, I doubted that at that point that we're going to have any responses. So I did the genetics, and with the genetic results, we just pushed through with no revaccination.
Okay, I think I have the same question as Dr. Rima, which is what's the explanation of the low C4? Can he have a primary C4 deficiency as well with his XLA?
Nothing popped in that genetic panel, and that genetic panel did look at complement deficiencies in detail. Actually, I did look, and it even looked at HAE, by the way, at hereditary angioedema, and there is nothing. That is genetic-wise, no. The plan for me is I actually today I did send a repeat of the C4. I wanted him to stabilize first. So now he's stable. He no longer has any infections. I was worried that the lab maybe is not handling the sample properly, but this happened at 3 different occasions at this point. So today I sent for C1q, C1 esterase inhibitor levels and functions, and I re-repeated the CH50. And I guess from there we can see if he keeps getting more infections, I can do a wider genetic testing and see if there is something we missed. But I'm happy to hear any suggestions for this.
I think for deficiency, it's quite, I'm not a geneticist, but the way the gene works, it's like there are 4 copies of the gene and you can have 1, 2, 3, or 4. So it can be quite a subtle part. And I think it's difficult to pick up because I had a patient with no C4, no C4. I've been following for ages. He's got a little bit of autoimmune disease. And eventually and they keep saying, no, there's no variant. And I said, and then they said, you know what, testing it is difficult. I can't remember the details.
Okay.
But he's on prophylactic antibiotics. He's on IVIG, so he's covered management-wise.
He's covered.
So there's a question. Yes.
But would you recommend things like functional testing for something like that? Like I think there is.
But you did CH50. What other functional test can you do?
Yeah, AH50. I'm not sure.
AH50 for C4, maybe yes, but it should come up on a CH50 if it was true deficient. And there's a question, a very interesting one. Is there a chance for bone marrow transplantation for this patient?
I think so. Yes, very much so. This is something that's becoming more and more prevalent now for patients with XLA. In the past, we used to say it's the easy one that you only give immunoglobulin replacement. But it's something that actually even the parents ask me about, and they're interested because they don't know if they want for the rest of his life the child to keep getting immunoglobulins. They would like a permanent solution. So this is something that we are talking about. Again, in terms of coverage and insurance, of course, insurance will not pay for this, but there are grants for this. So we're trying to explore options for the patient. Yeah.
Yeah, I think I remember I have 2 difficult patients with that. It's not a standard of care now because of the risks of bone marrow transplant, and you have a 20% mortality risk, and most patients do well or relatively well with immunoglobulins, but the lungs are the big problem. With time, their lungs tend to go off, and many of them may need a lung transplant. But there are cases who had severe infections like intractable norovirus infection, ones who had been transplanted where they really had severe infections who have had a successful transplant. So as you said, I think the future will be maybe, as transplant gets easier and safer, and maybe if gene therapy becomes available, it might be options for these kind of patients. I have a question myself. You commented about the allergic reaction is IgA deficient. Over my course of experience of a long time, I've never seen an infusion reaction to IVIG. And I always think this is overrated. So I do wonder what the audience is experiencing, what your experience is, what Dr. Mohammed experiences, what the audience experiences with this, because we keep saying it's in the textbook, it comes in the exam, but in real life, I've never seen it happen.
I've seen it one time. It was when I was working in the US. At that time, we were a very big IVIG center, and we used to see a lot of patients. And I remember there was one patient that actually reacted. She was under the diagnosis of CVID, but her IgA was very, very, very low. And she did react to IVIG. So the treatment was, initially we switched her to IVIG SD, which is a GammaGuard SD, which is one that has depleted. I think that's one of the few products that has depleted IgA. She did well on that, and eventually she was transitioned to HyQvia. But you're very right. Like, I think it is overrated. There are some studies that suggest maybe looking at anti-IgA antibodies, but even getting those tests were very, very difficult to do. So I think we just took our chances.
I agree with Dr. Hiba. I think I've given zillions of patients IVIG and subcut, etc. I haven't seen it. Theoretic, yes, it is theoretical risk, but I haven't seen it, and I think anti-IgA antibodies are difficult to measure, and there are no standardized test for it, and it's not routinely done. So I think, and there are lots of reasons why patients with IgA deficiency might get a reaction, but I don't think it is, as prevalent or as exaggerated as it is in the textbooks, etc.
Yeah.
Yes, I completely agree. Yes. Okay, so I think this brings us to the end of our two very interesting sessions. Our next session will be in June, inshallah. Please, if you have any interesting case, any difficult case that you don't know how to deal with, you'd like to be discussed, please message me and we'll meet in June, inshallah. Many thanks to our speakers, Dr. Mohammed, Dr. Fulvio, Professor Abu Zahkouk, and for Pearl for organizing this webinar. And we're sorry that Professor Denry couldn't be with us due to technical issues. Hopefully, next time we'll get this sorted. Thank you to you all. Thank you very much.
Great job, guys. Thank you very much.
Thank you. Goodbye.
Thank you, everyone. Have a great night.
Thank you.